It's time for another warm-up review. Let's get started. Complete the following diagram of the cell cycle. So right after mitosis, the cell goes into interphase, which includes G1, and then there is S phase, and then G2, and then back to mitosis, or sometimes referred to as M phase. That's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about drug elimination. And I'm not talking about when your mom knocks on your door and you hide your stash under the bed or chuck it out the window. This isn't high school anymore. I'm talking about how we eliminate drugs from our bodies. We talked about how our bodies metabolize drugs in another video, and now we're talking about how we get those drugs out of the body. When you give a patient a dose of a drug, you know the drug's effect will only last a certain length of time. Eventually, the body will inactivate the drug and then eliminate it. That's why you have to keep giving the drug every day, or twice a day, or however it's dosed. So we need to start by talking about elimination kinetics, which determines how quickly we're able to eliminate the drug. There's zero-order elimination and first-order elimination. We touched on this when we talked about the Michaelis-Menten enzyme kinetics. Zero-order elimination is where a constant amount of drug is eliminated per unit of time. Basically, it behaves as though the enzymes are saturated. It doesn't matter how much of the substrate there is. It doesn't matter what the concentration of the substrate is. The enzymes available to eliminate the drug can only work so fast. So it's basically saturation kinetics. No matter how much drug is in the system, it can only be eliminated at a particular rate. So if a drug is eliminated at 25 milligrams per hour, regardless of the drug concentration, that's zero-order elimination. Make sure you can identify that term. Another way to say it is that zero-order kinetics in the plasma concentration decreases linearly with time. So if you start out with a plasma concentration of 100 milligrams per liter, or whatever, and the zero-order elimination rate is 25 milligrams per hour. After 1 hour, the drug level would go from 100 to 75. And then after another hour, it would go from 75 to 50, and then 50 to 25, and then 0. So after 4 hours, in this example, the drug would be completely gone. There are 3 examples of drugs that are metabolized this way, using zero-order kinetics: phenytoin, ethanol, and aspirin. At least at toxic concentrations, aspirin is metabolized at a constant rate, using zero-order elimination. So you can remember the mnemonic P, P-E-A, and a P is round like 0. So definitely know phenytoin, ethanol, and aspirin. And then there's first-order elimination. This is where a constant proportion or constant percentage of the drug is eliminated per unit of time. Zero order was a constant amount per hour, but first order is a constant percentage per hour. This means that the plasma concentration decreases, not linearly, but exponentially with time. In other words, instead of eliminating a constant 25 milligrams per hour or whatever it was, like we saw in zero-order kinetics, with first order, you're going to eliminate a fixed percentage or proportion of the drug. So you might clear 50% of the drug out every hour. So the absolute amount of drug eliminated will vary, but the proportion eliminated will always be the same. So if you start out with the same plasma concentration of 100 milligrams per liter, and you're eliminating 50% of the drug every hour, that first hour you'll eliminate 50 milligrams. The second hour you'll eliminate 50% of whatever is left. So then you'll go from 50 to 25. And then in the third hour you'll go from 25 to 12.5. And in the fourth hour you go from 12.5 to 6.25, and so on. So with these numbers, after 4 hours of zero-order elimination has gotten you to a plasma concentration level of 0. But with first-order elimination, there's still a little bit of the drug left. So in this example, zero order clears the drug faster. But what if you'd started with a concentration of 500 milligrams per liter? With first-order elimination, still clearing about 50% of the drug per hour, you'd be at 250 milligrams after the first hour, and then 125 milligrams after 2 hours, 62.5 after 3 hours. You don't always eliminate 50% in an hour, that's just the example we're using. But if you had a starting concentration of 500 milligrams and the drug was eliminated using zero-order kinetics, and say it was still clearing at 25 milligrams per hour, what would the level be after 3 hours? Well, you started with 500, you cleared 25 each hour, so after 3 hours that would leave you with a level of 425 milligrams. So you can see that in this example, starting with a higher plasma concentration, first-order elimination clears the drug much, much faster. After a drug has been metabolized and inactivated, there are two main routes to get the inactive metabolites out of the body. You're either going to dump those inactive metabolites into the bile and excrete them in the feces, or you'll dump them in the urine. Renal elimination is a very, very common way of getting drugs out of our body. So let's talk about how the pH of urine can influence drug elimination. The first thing you need to know is that polar charged ionic species get trapped in the urine. Why is that the case? Ions don't cross through the plasma membrane very easily, right? Ions are hydrophilic, but our plasma membranes are lipid bilayers, right? So uncharged neutral lipophilic molecules that get filtered in the glomerulus and end up in the filtrate can pass through the membranes of the proximal tubules and be reabsorbed. But those hydrophilic ionized species get trapped in the filtrate and pass right through the nephron into the collecting system. So when we talk about ionic species, we're mainly talking about drugs that are weak acids and weak bases. Let's look at this in your study guide. Weak acids dissociate into hydrogen ions and an anion. Weak bases start out with a positive charge, and they dissociate into a hydrogen ion and an uncharged base. So pay attention to where the charged and uncharged forms are. This is pretty basic stuff. Not basic like alkaline, just elementary. I'm just giving you some background before we start talking about how this affects drug elimination. One of the other basic, elementary, fundamental pieces of information that you need to know is pKa. So what is pKa? That's the first bullet in your study guide, below the acid-base equations. pKa is the acid dissociation constant. The pKa is the pH at which the amount of a non-protonated form of the drug equals the amount of the protonated form of the drug. So at whatever pH the two sides of the equation are balanced, where the amount of acidic drug is equal to the amount of anions, that's the pKa. Or, if you're dealing with a basic drug, it's the pH where the amount of basic drug is equal to the amount of uncharged base. So that's the pKa, the acid dissociation constant. It's a pH value, and every drug has its own pKa, which you could look up if you needed to. The second bullet says, if the pH is low in an acidic environment, and more importantly, if the pH is less than the pKa for that substance, there will be more of the protonated form. When the pH is at the pKa value, the protonated and non-protonated forms are equal. But when the pH is lower than the pKa, the low pH means more acid, and there are more protons around, and those protons are going to bind to the anion and help tip the scale toward the protonated form. So this means that when the urine pH is low, if you have acidic urine, both acidic drugs and basic drugs are shifted toward the protonated form over here on the left. So which type of drug is going to be trapped in that acidic urine? The basic drugs, because the protonated form of that basic drug is the charged form. And we started out by saying that charged ionic species get trapped. So in acidic urine, the drugs that are weak bases will be trapped. But acidic drugs, when they're protonated, they're not charged. So the basic drugs will get trapped in the acidic urine. Those basic drugs can't cross through the plasma membrane anymore, so they stay in the urine and get excreted, while the acidic drugs can be reabsorbed into the body. The third bullet says that if a pH is high, which would mean basic environment, and more importantly, if the pH is higher than the pKa, then there will be more of the non-protonated form. So when the pH is high and you don't have as many protons around, the equations shift toward the right so that your weak acids will have a charge and your weak bases will be uncharged. And that means that in the basic alkaline urine, acidic drugs, the charged ones, are going to be trapped and excreted out, but basic drugs will be reabsorbed. Now, why is this important? Look at the next two bullets. In order to treat an overdose of acidic drugs, such as aspirin, which is salicylic acid, in order to treat an aspirin overdose, you're going to use sodium bicarbonate. Again, you can treat an overdose of acidic drugs with sodium bicarb. That bicarb is going to be excreted into the urine, and then the urine becomes alkaline. And what did we just say happens to weak acids in a basic environment? Those weak acids are going to be trapped. And that's how you can get rid of acidic drugs like aspirin. You trap it in the urine by giving a base like sodium bicarb to alkalize the urine, and then it traps the acidic drug there. When the aspirin is trapped in the urine, it can't be reabsorbed, and then you can urinate it out. Now, don't get confused. You might think, well, if I give IV bicarb, I'm going to alkalize the serum, and then the aspirin is trapped in the serum. That's not what happens, because the body will concentrate the bicarb in the urine, so the drug gets trapped in the urine, and it's a much more important principle there. Then the last bullet says, to treat overdoses of basic drugs like amphetamines, you acidify the urine by giving ammonium chloride. So ammonium chloride acidifies the urine and traps those basic drugs in the acidic urine. So you give bases to help eliminate acids and acids to help eliminate bases. So that's pretty much it for drug elimination and urinary pH. Next, we're going to go over something that really has nothing to do with drug elimination, but we've got a little extra time in this video. These drug suffixes are great to know because they can help you identify a lot of drugs very quickly. If you know these, you may be able to identify what a drug does based on the suffix. And if you're not that familiar with that particular drug name, this can really come in handy. In your study guide, there's an enormous table with about 35 suffixes that I think it's worth your time to learn. I'll bet you know a bunch of these already. Some of these are listed in your review books, but a lot of them aren't, so let's just go through the study guide. The first one is AFIL, which are phosphodiesterase inhibitors, the erectile dysfunction drugs. Sildenafil is one example, and that's Viagra. Another one is tadalafil. Azepam is a suffix for benzodiazepine, like lorazepam or diazepam. Azines are the phenothiazines. Some of the phenothiazines can be used as neuroepileptics, like chlorpromazine or thioridazine, and then other phenothiazines are used as antiemetics, like promethazine. Azalam is another suffix for benzodiazepine, such as alprazolam or midazolam or triazolam. So azalam and azepam are both benzos. Drugs that end in barbitol are barbiturates, like phenobarbital and secobarbital. Bendazole are antiparasitic drugs, like mebendazole or albendazole, which are used for worm infections, like helminth infections. You can think about how worms are bendy, and you can use bendazole to treat those. Caine are the local anesthetics, like lidocaine and tetracaine. The next one is col. If you see col, you'll know it's a cholinergic agonist, like muscarinic agonists, like bethanacol or carbachol. Cillin are the penicillins, like amoxicillin or methicillin. Conazole are antifungals, like fluconazole or ketoconazole. The chemical class in these is called imidazole, and lots of people call these azole, antifungals, to distinguish them from other antifungals like nystatin or amphotericin. But the problem with calling them azoles is that there are other drugs in an azole, like metronidazole, which is an antibiotic, not an antifungal. And there's mebendazole, which, like we just mentioned, is used for worm infections. But if you see conazole, definitely antifungal. The next two are curium and curonium. And these are non-depolarizing neuromuscular blocking agents, like atacurium or vecuronium or rocuronium. Rocuronium always sounds so cool. It's kind of like a radioactive hair metal band. Rocuronium. The cyclines are a type of antibiotic that inhibit protein synthesis, like tetracycline or doxycycline. Dipene are calcium channel blockers, specifically dihydropyridine calcium channel blockers like nifedipine or amlodipine. Dronates are the bisphosphonate drugs used to treat osteoporosis, like alendronate or risodronate. Teens are SSRI antidepressants like fluoxetine, which is Prozac, and paroxetine and sertraline. Fluorine are the inhaled anesthetics like isoflurane and sevoflurane. Gliptins are DPP-4 inhibitors, which are a class of drugs used to treat type 2 diabetes. The examples of these drugs would be sitagliptin and saxagliptin. Glitazones are also diabetes drugs. Glitazones and thiazolidinediones, or TZDs, which increase insulin sensitivity. These are pioglitazones and rosiglitazone. Ipramine are tricyclic antidepressants like chlormipramine or imipramine. MAB is actually an acronym for monoclonal antibody. Whenever you see a MAB at the end of a name, that's a monoclonal antibody. Infliximab or rituximab would be a couple of examples. The next one is mustine. Mustines are nitrosoureas, which are cancer drugs. These are drugs that readily cross the blood-brain barrier and treat brain tumors. Also, because they cross the blood-brain barrier, they can cause CNS side effects. That makes sense. Navir are protease inhibitors used to treat HIV, like ritonavir or saquinavir. These would be a couple examples of the long list. Remember, we said in the last video that these are also cytochrome P450 inhibitors. Olol are beta blockers like atenolol or metoprolol. And remember, there are two exceptions to this olol suffix, which are carvedilol, which ends in ILOL, and labetalol, which ends in ALOL. These are beta blockers that also block alpha receptors, so the different spelling might help you to remember they have a slightly different function. Operadol are another type of neuroleptic, like haloperidol and droperidol. We said that azine was a suffix for phenothiazine neuroleptics, like chlorpromazine. Well, haloperidol is a different chemical class of neuroleptics. Phyllin are the methylxanthines like theophylline or aminophylline. Pril is the ACE inhibitor, like enalapril or lisinopril. Prost is the prostaglandin analogs. These are for drugs like latanoprost or travoprost, which are used to treat glaucoma. The next one is sartan. These are the angiotensin II blockers like losartan and valsartan. Statins are HMG-CoA reductase inhibitors used to lower LDL levels, like atorvastatin or simvastatin. Stigmine is an anticholinesterase inhibitor, the so-called indirect cholinergic agonist, like neostigmine and physiostigmine, and also rivastigmine, which we use to treat Alzheimer's disease. Pterol is a beta-2 agonist like albuterol or salmeterol. Tadine are histamine antagonists, H2 blockers like cimetidine or ranitidine. Triptans are drugs like sumatriptan, which you might know better as Imitrex. These are serotonin agonists, serotonin 1B, 1D agonists, which are used to treat migraines. Triptylin is another group of tricyclic antidepressants. Amitriptyline and nortriptyline would be examples. So TCAs can either end in ipramine or triptyline. Tropin are pituitary hormones like somatotropin. And the last one is zosyn, which are the alpha-1 antagonists like prazosin and doxazosin. Whew, I know that's a huge list, and I know that students can find these drug names and classes really very frustrating. It's like learning a foreign language. But I would strongly recommend that you make some flashcards and learn these. Be able to match the drug with its class or its action based on its name. It'll really help you, especially when you get into the hospital and in the clinic. Now we're ready for the end-of-session quiz. So I want you to pause the video and work through those questions, and then we'll go over the answers together. First question, which medication overdose can be treated with sodium bicarbonate? You use bicarb to alkalinize the urine, which is going to trap weak acids. So you use sodium bicarb to treat overdoses with weak acids like aspirin. Which medication overdose can be treated with ammonium chloride? This is going to acidify the urine and trap weak bases. So this is used for treating overdoses of drugs that are weak bases, such as amphetamines. To what class do each of the following belong to? So these are all suffixes that we just finished discussing, but we didn't list any of these specific drugs. So I'm hoping you'll be able to recognize these are all drugs that act on the autonomic nervous system. So hopefully this is a little bit of a review for you. Methacholine. That's a cold drug. That's a cholinergic drug, a muscarinic agonist. Propranolol. Olol is a beta blocker. Proteostigmine. Stigmine is an anticholinesterase. Formoterol. Turol is a beta-2 agonist. Formoterol is actually a long-acting inhaled beta-2 agonist. And terazosin is a zosin drug, an alpha-1 antagonist. All right, that's it for this video. We'll see you next time.